Good morning and welcome to our penultimate food bank show. I hope you've enjoyed the series. We had no idea when we started it that we'd end up doing 50 days in a row, but that's what it will be tomorrow. Thank you for all your support. Thank you for those that have been joining in the live debates and asking some brilliant questions. And also thank you so much to those that have given to giving to the Trussell Trust, who are running 1,250 of the food banks across the UK. If you haven't yet made a donation, really, if you could, just a small one via text or by the number. Many people across the country right now, in fact, more than ever, are needing support. We're putting meals on the table for their families simply because of the crisis we find ourselves in today. Now, tomorrow, don't ask me how yet, but Jack and the clever people that work behind the scenes will work out how we find a winner to our two competitions. The one competition was show us on Facebook, on Primal Living on Facebook, what you cooked for the first time yesterday, and we've been some great recipes that you've been putting on there. So that's the one competition. And the other competition is to look for the food facts in all the previous 48 episodes up till today, although I think we missed 2 or 3 of them. And whenever you see the green bit come up, write down the word that was the food. So today's is going to be sardines, and just write down what the food that was in discussion, and then we're going to ask you to email us all your answers. We're going to tomorrow give you an email address to send those to, and then if we have some joint winners, we'll find a way of fairly picking a winner. And the prizes are pretty good, actually. You can have either £1,000 worth of jewellery, beautiful jewellery, courtesy of Gemporia, or if you should choose, you can come after lockdown's finished to a boutique hotel in Warwickshire, where we're all from, and Jack, myself, Poppy and Nick have put the show on. We'll all get together and we'll put you up overnight, and then we'll have a nice healthy meal together and have some fun. You choose which prize, but we'll be announcing them tomorrow, Jack, or we'll decide tomorrow, because that's the last day, and then we'll I don't know, we'll put something up on YouTube and Facebook and what have you. Now, today's show, we have a really good friend of mine, Dr Malcolm Kendrick, author of Doctoring Data, author of A Statin Nation, and author of The Great Cholesterol Con. All 3 of them amazing books indeed. He's a brilliant GP up in Cheshire, on the front line, and an author, and can sometimes be controversial, which is what I really admire about him. And let's get straight on. So, good morning, Malcolm. How are you?
Good morning. Yeah, lovely sunny Macclesfield. I've had to close the curtains to stop unusually to stop the sun coming in and blinding me. So I'm slightly more lit on the left-hand side this morning, I think. But so surviving, yeah.
Just adds to your beautiful good looks, mate. Don't worry, it's just like you lit up like a supermodel.
Long hair. I'm reverting to the 1980s. I think it's a mullet.
Well, I guess you've not had time to cut your hair. You've been on the front line. What's the front line look like for the last week or so?
Well, it's calmed down quite a lot. One of the units I was in is actually, we've managed to convince them to clear the COVID patients out back into hospital, and I believe they're talking about opening up the Manchester Nightingale. I don't think it's called the Nightingale. It's the equivalent of the Nightingale, so they can move patients out of the hospital and hopefully start to look at doing the things that hospitals used to do before COVID, and starting to do them again, because there is a huge backlog of people building up who really need operations, who need chemotherapy, who need all these things that are just not been happening. So things are definitely calming down, although one of the nursing homes I go into, 50% of the staff are now off with COVID positive tests.
Oh.
So, that, still the legacy of throwing people into care homes out of hospitals, COVID positive, is still running through the system, and it's just something I have jumped up and down about for the last few weeks and become increasingly frustrated with. So that's a downside. Another downside is, I say, we just got some new PPE masks delivered to us in one of the units, and with the out of date sticker on it saying 2022. But if you pull the sticker off the out of date, and this is 2017. So somebody's been whacking stickers over the expiry dates in order to pretend that things are still in date, and that is something that I'm not entirely happy about, as you can imagine.
Oh, that is just, well, in the commercial world, would be locked up and put in jail for things like that, to be quite honest. So,
I was speaking to a friend who does aircraft design stuff, and I said, imagine if you got an aircraft and said, well, I know it's supposed to 40,000 hours in the air, but actually we've decided it can do another 40,000 hours in the air. We haven't done any testing on it. We've just put a new sticker on the side saying this plane is okay for another 40,000 hours. You just can't imagine the thinking that went on there. So not happy, put it that way. Anywho,
that's terrible. I mean, you'd rather have it arrive saying out of date, and then you can make the choice of whether to use it or not, as opposed to thinking you're completely safe and going into battle on the front line with the virus with inadequate equipment.
Well, absolutely. I mean, I think, when stuff like this, you think, well, probably I can't quite see how it goes out of date, if you like. It's a mask, but maybe, who knows? But obviously over time things degrade, but that is a choice thing. But so somebody's decided we're not going to give people that choice. We're just going to pretend there is no choice.
I mean, again, I don't know why it goes out, but maybe the filtration in it, the actual mesh just degenerates over time, maybe.
Well, yeah, I mean, I haven't looked into it. I have no idea, but I think, as you say, if someone said, look, mate, this is, sorry, this is all we've got. Maybe they decided, maybe they spoke to the lawyers, and the lawyer said, well, you can't say that to them, because then you're putting people, they can just say, I'm not working if that's the equipment I've got.
Yeah.
And then all the staff go. So whatever it was clearly just a decision that was made with no one's best interests at heart, was it?
No, absolutely. So how do you feel that, with the exception of these masks, how do you feel we've dealt with COVID crisis as a nation, with the exception of the masks?
Well, that's a big question. Too big. I think that one of the big problems, of course, you start off was the modelling was done. The modelling that seemed to have ruled the world was done by Imperial College, where they just basically came up with a bunch of figures that they had no idea really whether they were right or not, and then said, if we don't do anything, 500,000 people are going to die of COVID next year. And there seemed to be very little questioning of this, and very little like, well, where did that come from, and what figures are you using, and da-da-da-da. So, and still, we see little about this. I mean, we know that the main architect, Neil Ferguson, ended up breaching the social distancing rules, should we put it that way, and therefore his face has gone from it. But we still seem to be using the same figures, and then you look at, well, what is the actual likely mortality rate? What's going on? And it's incredibly difficult to establish what's happening around the world, and it's hugely different. In the UK, where we are at the very top end of deaths and deaths per 100,000 and deaths per million or whatever, and you look at other countries, Australia, for example, last time I looked, although their lockdown worked less well than ours, there's people rushing onto Bondi Beach to go surfing. They have had 98 deaths in total. That's it, and they haven't had any for a while. So I think that if you're going to do something as drastic as locking down the entire country and passing emergency laws, you have to be a bit more certain about what your figures are, and then you have to be more willing to accept, these figures are wrong. We now know these figures they must be wrong, because the countries that have had more cases and more testing have shown that the what they call the case fatality rate, which is the number of people who die, is well below 1%. In Iceland is the most tested country, and although it's a small country, the case fatality rate, which is the people who've got and express symptoms who die, is 0.55%. And we know that about 50% of people who get infected, the 50% of people who get COVID don't show any symptoms at all. So they're asymptomatic. So they can't be cases. So that's what you call the infection fatality rate. Must be 50% less than the case fatality rate.
Yeah.
So the maximum infection fatality rate is 0.27%, according to the accurate figures we've got, which would lead to a maximum death rate in the United Kingdom of about 130,000, assuming 80% of people get infected, which is an incredibly high percentage. So the figure of the figures that we're using on the infection fatality rate are wrong. The figures they're using on numbers of people who are actually likely to get infected appear to be vastly overestimated. So we have worked on the basis of a model which is hopelessly inaccurate, and yet no one is even suggesting, well, what figures are accurate. It's almost like, well, those are our figures and we are not going to change them, which is, that's their prediction. As a friend of mine said, prediction is there's two forms of forecasting. There's lucky and lousy, and we've had lousy, I think, and yet no one discusses this stuff. So anyway.
So that's on the forecasting. Let's go back to Australia then. So Australia's population is around 22, 23 million. We're 60 something. So we're 3 times bigger than Australia, but they've had less than 100 deaths. So that would be then, say, if they had the same population as us, that would be 300 deaths. So they are still some 100, we're almost 100 times more per population than Australia, if my maths are right, 100 times more, that's right. Is that then that Australia is under-reporting, or are we over-reporting? In other words, are people dying of COVID, dying with COVID, but really they're dying of something else? They just happen to have COVID as they pass away, or?
Well, I don't think the problem is that the statistics at the end of this are going to be very difficult to answer because, I've done death certificates and I'm not entirely sure they're terribly accurate. If someone's died in nursing home and they've not been tested because no one was allowed to be tested, elderly, vulnerable people die in nursing homes. Was it definitely COVID or was it definitely not COVID? What am I supposed to say?
Yeah.
If you speak to the coroner, they just sort of say, "Oh, put COVID on it," or "Don't put COVID on it." So I'm pretty sure I've both over and underreported in my 4 death certificates that I've ended up doing. I mean, most of them end up going to hospital where things can be more certain. So I think in the UK we're both over-reporting and under-reporting simultaneously, which is a clever trick. Definitely Belgium is the country with the highest mortality rate per head of population. But it seems that they just put down almost everything as COVID. So you fell out of an airplane, hit the ground, you'd be died of COVID. So, unless we are very clear about what we are, how we're diagnosing it, and every country is the same, and every country is clearly not the same. I mean, the fatality rate per head of population in China is per million is 3.
Yeah.
So and they've got a population of 1.4 billion or something, so that's still about 5,000. Yeah. Whereas ours is running at something like 500.
Yeah.
I mean, the Chinese, they locked down, but before the lockdown, they had this sort of celebration, didn't they, where everyone rushed off around China and traveled and met everybody. So there's no way they kept that under control that effectively, because when it was at peak, they were all charging about the countryside.
Yep.
And then we've got Sweden, who have not locked down. Oh, they've locked down less. I mean, they're not living as they used to completely. So they've kind of semi-locked down. I mean, their fatality rate per million is about half of ours.
Yeah.
I mean, it's more than, say, Norway or Denmark, which are close by countries which did more lockdown. And then you look at New Zealand, which has now had even less deaths. It's like 20 deaths, I think, of COVID. And you think, well, what did they do? Well, they did lock down. And of course, they're a bit more isolated as a country. But you can't, once this thing was circulating around, it circulated around for a while. So the figures on one aspect almost just don't seem to make any sense,
Yeah.
So I don't think you can tell terribly much. But what you can also look at and say, it looks very much like Southern Hemisphere countries got away with this.
Mm-hmm.
South Africa's got a population similar to the UK. I think they've had 300 deaths. Mm-hmm. India's got a population of even more than China's, I think. And last time I looked, they had under 1,000 deaths, which makes the Australian figures look like nothing. So, what is going on? you know, and you know that one of my things that I jump up and down about is saying, well, have a look at vitamin D, people. Have a look at vitamin D.
Yeah.
Measure vitamin D levels. There was a study done in, I think it was the Philippines, where the people with adequate vitamin D, this is a small population study, it wasn't a huge number of people, were 19 times less likely to die than people who had deficient vitamin D levels.
Yeah.
Now, that's one study. You know, people say, oh, it's a small study. To an extent, I would say I like small studies, because if you can show something in a study of 200 people, it's almost certainly there. If you have to have 10,000 people in order to show some microscopic but statistically significant effect, it's probably not there. You know, we're finding something of such insignificance anyway. So I prefer to see things in studies. You know, when antibiotics first appeared after the Second World War, they didn't have large studies. They didn't have 10,000 people in either arm. What they did was they gave antibiotics to people, the troops who'd been, you know, shot and injured and were dying of infections, and they wanted to see what happened. They said, oh, look, they're all getting better. So they only needed a small number of people because the effect was so huge. To have a huge effect, you only need a small amount of people in your study. If you have a microscopic effect, you need a huge number of people in your study.
That's a really good point.
People nowadays say, oh, if it's not a study of 10,000 people in either arm, the study was too small. You go, no, it just means that the effect was so huge. So once you start seeing a 19-fold difference, which may be proven in other studies or not, that doesn't need many people to become statistically significant. So I do look at people and raise my eyebrows. Like, we've been trapped in a way of thinking about studies on diseases that is like the experts say, well, it was a huge study, so it's definitely an effect. And I go, well, if it's that small an effect, it wasn't worth doing the bloody study. So you know, you can argue that one, but I still
no,
say,
I'm 100% with you. You know, for something to really be beneficial, you need a high percentage, and therefore you don't need a lot of people. So back to Australia, you know, so it is. I've just checked my maths there. It's 100 times different outcome. So you are 100 times. Okay, so now it comes back to: are we using absolute numbers, or are we using what's the?
Well, those are absolute numbers. They have a per million population. They have 100 times less deaths from COVID.
That's right.
So I don't think reporting can explain that.
So,
I mean, the Australian healthcare system and our healthcare systems are, you know, similar, very similar.
So let's shout out some possibilities then. It could be a different strain, but everybody's saying it's all pretty much the same strain of the virus. Your vitamin D hypothesis sounds really good one, because they are just coming out of summer both in Australia and in New Zealand, so their vitamin D levels will be high. The people it's been affecting most in the UK are those in care homes, who will have very low vitamin D levels, I would have thought, unless they're on supplements or medication. The elderly tend to be indoors more than the younger generation. It's affecting those. It's affecting the BAME, the Black and Asian communities more. They'll definitely have lower vitamin D levels. It's certainly plausible that may be one of the key factors.
Well, I mean, you've got almost everything that quacks in there that makes up a duck. I mean, they have done, I was looking at a study from about 12 years ago looking at influenza and giving people vitamin D supplementation. And again, this was a small study, but I can't remember the exact figures, but out of, I think it was 160 people in either arm, the ones that were given the highest dose of vitamin D supplementation in the second year where they gave it, only one person suffered anything cold or flu symptoms, whereas in the other arm it was something like 25. So we are looking at, again, you can't use those figures to define anything for sure, but there have been studies done. I'm not going to say this is the only possible thing that is causing a difference, but I know that I was looking at Sweden, and a huge number of their cases who've died have been from Somalia. I think it's Somalia, not Sudan. Somalia, where they had a lot of refugees, and it's something like they make up 0.2% of the population, but have made up something like 30% of the deaths. Those figures are not right, but it was something so gigantically different, you know. And there are issues to do with people from ethnic minorities tend to have more, they tend to be more crowded housing, and they tend to be at the lower end of the spectrum, and they tend to have more front-facing jobs. So we see people like bus drivers have been affected in London more than frontline medical staff, that's for sure. And they tend to be at the lower end of the social spectrum, unfortunately, and they tend to be Black and Asian minorities. So there are issues undergoing there, and there are some also some interesting effects to do with the cardiovascular system and the way that operates slightly differently, because you use different medications in Black and Asian groupings than you use in Caucasians. In fact, the listing, if you go to NICE and it says which drug should you use first to lower blood pressure, it's different in the Black population than the white population because they react differently, and that's to do with receptors and ACE receptors and things like that in the system, which are different in these different groups. So there is something there as well. So it's not all one thing, obviously, but another aspect is well, there's no major aspect is definitely to me the vitamin D. And the frustrating thing is, again, we do things in medicine. I was thinking about this before coming on the show. We use things like ventilators. No one has done a study to say, is it better to be on a ventilator than to be on continuous positive airway pressure? That's called CPAP. That's the thing where they put a mask on and push higher levels of oxygen into you. So, but people will stick people on ventilators and use CPAP. Mercedes came along with their special device that helped CPAP to be more effective. How many clinical studies were there on that? None, and yet it's being used. Ventilators are being used. They were being used at a very high proportion. And I asked this question on the Doctors Net site where one of the doctors discussed things. I said, well, how many people has ventilation saved? So how many of the people you ventilated would be dead if they didn't have ventilation? Would it be 100%? Would it be 90%? What's the benefit of doing this? Well, they don't know because there's been no studies done on this. It's completely study-free. We're happy to use things like ventilation with no studies at all. It's just, well, of course we've got to ventilate people. And it has turned out that we've been over-ventilating, and it's better just to try and use CPAP in a lot of people. And we've been covering that on the hoof. So we have been harming some people, many people, I don't know, with ventilators. That's not really the point. The point is, on one side, we're happy to stick people on ventilators and stick people on CPAP and use this Mercedes special device that helps to coordinate the ventilation of CPAP with no studies whatsoever. It's just being done. Bang. And on the other side, you try and say to people, use vitamin D, they go, oh, we don't have the studies. You go, oh, hold on. On one side, you're treating people madly with no evidence that you're doing any benefit. If you go back, and you know that I've written this in Doctoring Data, looking at things like strict bed rest following a myocardial infarction, which was the standard treatment. That was what you had to do. Someone had a heart attack. They must lie in bed for 6 weeks. They must not move a muscle. They must be sort of fed. They mustn't move. And if you didn't do that, this was absolutely disastrous. Because one of my heroes is a guy called Bernard Lone, and he was the first to say, do you know what? I think lying people in bed for 6 weeks is not a very good idea. And he got and sat them at the terrible thing, sat them at the end of their bed. And the other doctors sent medical students into his ward with coffins over their shoulders written murder on the side. All right? Because you were murdering people because you weren't following the standard correct treatment. And no one questioned it. And this treatment, my back of a fag packet calculations were tens of millions of people died because of this form of treatment. And no one questioned it. Because Bernard Lone was another man, when he looked at coronary artery bypass grafting, he said, I'm not so sure this is really beneficial. And yet at the time, when it came in, you've got a blockage in your artery. It's a widowmaker. We must operate on it. And then when he tried to look at it, he eventually found in his study, it took him 4 years to eventually get it published, that it really, in most cases, did no good whatsoever. And in a lot of cases, caused quite a lot of harm. And this is, again, we seem to be incredibly happy to do some things. Just bang, do it. Oh, yeah, let's do a coronary artery bypass graft. That must be beneficial. And yet, on the other hand, I'm sitting here saying, vitamin C seems to be really beneficial. And there's a lot of reasons why it should be beneficial. And yet the medical profession is like, there's no studies, don't be stupid, go away. They're not even trying it. So on one hand, we have a requirement for evidence which is ridiculously high for something that can cause no harm. And on the other hand, we're doing thousands and thousands of things for which there is no evidence whatsoever, which the technical causing harm is huge. So it's bonkers, in my opinion.
And back to your point, they're saying, well, we haven't had those trials with thousands of people. And your point earlier was you don't need thousands of people if small trials prove, beyond doubt. And, while they're saying there's no, back to vitamin C, while they're saying there's no trials, well, Patrick Holford's been on quoting trials that have happened in China, in Italy, in certain hospitals in America, where, there might not have been countrywide with thousands of people, but the percentages of people, when they sort of give them intravenously vitamin C, the percentage of people was so significantly saved that you can't really argue with it.
Oh, no. And, I mean, if that level of benefit was shown for ventilators, we'd all be jumping up and down, but we don't have that evidence. Absolutely. I mean, I have looked at these trials and they're just dismissed. Oh, they're too small. They didn't have a proper control group, blah, 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 blah. I mean, well, you're in the middle of a bloody pandemic. Where are you going to get control groups? Let's get 10,000 in each arm. Let's have one lot in. Let's take 5 years. Let's say. I mean, I did write this thing saying, we're in a war. This is not peacetime medicine. This is wartime medicine. This is not a time where you can be doing, of course you don't want to do ridiculous things in case you harm people hugely, but you have to take a bit of it's not even a risk. What's the risk?
It's not risk. It's not a risk, is it? Because there is hardly any, if you look at the data in America, from the, I can't remember what that society is called now, but the people that look at the deaths in America, over the last 10 years, I think it's one person 10 years has died of any overdose of vitamins, none in Europe, and yet hundreds of thousands of people die with wrong medication or too much medication or over medication. Therefore, we know vitamins are safe. So if there's some blinking evidence that says, give them vitamin C, give them vitamin D, why is that? It doesn't have to be one or the other. If you then think ventilation's right, or this is right, or that's right, but why not just do it? Because it's not expensive.
Well, it is not expensive. No, I mean, this is, one can go into the psychology of it, but would end up being rather insulting of some people. So I choose not to go down that route. But I mean, it is. I mean, also, they've done studies in sepsis in the States and in India, which demonstrate that if you give steroids, high-dose vitamin C and thiamine, which is vitamin B, this has significant benefits in patients with sepsis. And although it may not seem the same thing, what we're seeing with COVID is it's causing. I mean, the thing that kills you in sepsis is the bacteria release all sorts of nasty substances that then get into your bloodstream and attack what you call the endothelium, the lining of your blood vessels. This attack on the blood vessels causes a reaction which causes blood clots to form. So what you get is a thing called disseminated, which means widespread, intravascular within the blood vessels coagulation, DIC. Disseminated intravascular coagulation is the primary cause of death in sepsis because you get lots of little blood clots in organs. They then shut down and fail, and that's why you die. And in COVID, we seem to be getting quite a significant thrombotic problem, coagulation problem, which in a way is exactly the same thing. Because what seems to be happening, and this can get confusing, but the virus gets into your cells through a thing called an ACE2 receptor, which is angiotensin converting enzyme receptor, but don't worry about that. That is the point of entry. But if it blocks these receptors, then you get a buildup of what they call superoxides. And the superoxides can actually damage the blood vessel, the lining of the blood vessel, in the same way as the toxins produced by the bacteria can cause the same problem, and therefore can cause this coagulation problem, which is causing most or a great deal of the deaths. And what seems to be happening is the body, in order to protect itself, burns through vitamin C to protect itself, so runs out of vitamin C. So we seem to be seeing an almost a kind of what they call, it's called scorbutic, which means low vitamin C. And so when you're in a COVID crisis and your blood vessels are being attacked, your body needs vitamin C in order to protect itself against what's happening. And this is confirmed slightly. You may have heard of this condition where young children are getting this weird autoimmune disease, which is very similar to a condition called COVID, not COVID, I'm talking, very similar to a condition called Kawasaki's disease.
Yeah. Mm-hmm.
And Kawasaki's disease is an unknown cause immune attack on the vascular system, vasculitis, all right? So that's the same thing as happens in sepsis. It's the same thing as we seem to be seeing it happening in adults in COVID. And the problem again with this vasculitis is, again, it's attack on the endothelial cells and inflammation in the arteries in the heart. The children who get Kawasaki's can die of heart attacks aged 4 due to the damage being done to the vascular system. And they get this clotting problem. So what we're seeing is around the system, and this would make sense with the specific damage to this, what they call the ACE2 receptor in the vascular system, and these also exist in the lungs. So the virus is getting in through these receptors. That's causing this trigger up of damage to the arteries. It's causing the clotting problems, and the clotting problems are killing people. And one of the ways you can help to prevent this is with vitamin C. We know this.
Yeah.
Right? And yet you cannot get your average cardiologist or treatment COVID person even to pay any attention to this information whatsoever. It is like banging your head against a concrete pillar. They will not respond.
Well, definitely listening to you and all the experts, and I absolutely mean this 100%. If any of my family get struck down with it and end up in a really serious position, I would be saying, you know, I'm not sure about the ventilation, but please, vitamin D, vitamin C, let's get them topped up. It just, to me, it's common sense. It's just common sense. And thank you for talking about Kawasaki's disease, because that came up as a question yesterday. So you've answered that without me having to ask you, which is fantastic. Right, lots of questions coming in. Some you might want to answer, some you might not, because the first one is very much a medical question by Russell. He says, is CVD that's stabilized and now with good metabolic markers still a high risk? Hypertension is very variable but medicated.
High risk for COVID, you mean, on this one?
I guess, yeah, he didn't actually put that in.
Well, I mean, it's been in fact, one of the key things that seems to be emerging is the risk of diabetes or obesity, diabetes, insulin resistance, and whether that's the underlying factor. Because obviously, when you've got that, you tend to have high blood pressure, you tend to have these other things. So the problem is, where's the core problem, and where are the associated or ancillary problems, if that makes sense?
Yeah.
So you know, in one of the things that was interesting in Italy when it came in was that the essentially having other risk factors or comorbidities was absolutely key to whether or not you were going to be seriously ill and die of COVID, and it is in most countries. So things like having high blood pressure, things like having diabetes, things like having COPD, these things are significant. But are they the actual thing, or is it the thing that underlies that thing? I'm sorry to make things more complicated, but they always are. So, you know, if you were like a 75-year-old, perfectly fit and healthy with no comorbidities, how much more at risk would you be than somebody who's got the comorbidities? Difficult to answer, but I think only 1% of people in Italy that died had no comorbidities. So is it the age thing, or is it as you get older you get more comorbidities? So is it as you get older you're more at risk? Is it the underlying thing like having insulin resistance and diabetes that makes you at risk? To an extent, you can say, well, it doesn't matter, because if you're on antihypertensives and you're obese and you've got diabetes, you know, stay away from other people at the moment, because you really are at high risk. I don't know if that fully answers the question, but
no, I think it does, because again, you know, if you said it was just people that had got metabolic syndrome or any of those diseases, only those, and everybody else was fine, then you'd say, well, that's obviously is the main thing. But the fact that occasionally people are getting it that appear to have no underlying medical conditions would say to me, you're more at risk if you've got them. But I guess viral load must play a big part of it as well, in the amount that you've been exposed to. In other words, you know.
Well, that's a difficult thing to know, because nobody really knows what viral load anyone's been exposed to. So that's a complex question. I mean, to an extent, with, you know, viral, it's called, you know, exponential growth. If you get one virus in you and it's growing every 10 minutes or however long it takes to replicate, it doesn't really take long for the viral load to become the same as it would if you got 25 million or 25 billion viral particles.
Yeah, got it.
So but whether if you've got one or two, then the body gets a chance to start working out how to attack it before it gets big. I mean, intuitively, yes. If someone coughed a huge amount of virus into your face in one go and you breathed it in, then it's going to be firing through your system much faster than if you just got 2 viral particles and then they spent ages becoming 4 viral particles and 8 viral particles. So yes, theoretically, although there was a very fascinating study from after the First World War when the Spanish flu that actually started in America came along, and what they got people who just got the Spanish flu and the symptoms, and they got their secretions out of their nose, and they stirred it around in a dish and then sprayed it into volunteers' faces. Oh. And they couldn't infect anybody with it at all. Wow. They were unable to give anybody a secondary infection. But they started doing that, and then they got people who were really ill and coughing and spluttering to like stand, that close to somebody and cough at them for about 5 minutes, and they couldn't get anybody infected doing that either. So, which is interesting, fascinating. Yeah. And to me suggests that the people who may be spreading this disease may well be people that you don't think have even got it, which of course makes it sneakier. But if I was a virus, I'd choose to infect people while I didn't have causing symptoms in the host, because other people would stay away from me. I would sneak around.
Well, you said right at the beginning of this hour that 50% don't even show symptoms, and that's the frightening thing, isn't it? Yeah, because you're right. People forget that viruses don't want to kill the host. Viruses want to keep the host alive to help it spread, because the second they murder the host, that's the end of that path, that journey. So it's fascinating. Now, Andrew Hunt said, I know Andrew only from coming on to this show. I know he said at the beginning he was ex-military. He said this is done quite regularly with PPE. That's frightening. That is frightening. The child psychotherapist says, hello, loving your show. How do you think present situation is affecting children's mental and physical health? It's a brilliant question. I think it's going to be different for lots of different people. Even in my own family of 5 young children, they're all taking it slightly different. I don't know if you want to add to that one at all, Malcolm.
Well, I think I don't think I have any particular expertise in that area, saying that some will probably be loving it, best thing ever happened, and others will be absolutely hating it. Was it done for general health? Well, if you can get out in the sunshine in the garden and get a bit of vitamin D, and go out for some nice walks, fine. I think that I don't know. I think we'll find that out. Yeah.
Because I'm convinced it'll go both ways. If the parents are screaming and not coping with it, and the kids are having a hard time, then they'd rather be back at school than others are, like say, out in the sun. And it's just, who knows? We'll have both. We'll hear these, and I tell you, the next 10 years, that's all we're going to hear. Stories we'll only hear the bad ones, but there will be some good stuff that comes out as well. Callum says, reading your book now, A Statin Nation, really enjoying it. Well done, Callum.
Good man. I like that question.
Primal Living said, well done, we've raised now £26,000, so well done to everybody. Child psychiatrist, I can't say the word, I said it a minute ago, but there you go. I'm worried children now in vulnerable families are going to be eating even worse with economic downturn and high levels of family stress. That is, I'm with you, it's just terrible, terrible, terrible. And Andrew's come back and said he agrees that more vitamin D in Australia. Keisha says, huge respect for Malcolm. To me, the lockdown has caused deaths, and I've been in A&E twice in the last week, and it's empty. And the junior docs are worried where all their stroke and heart patients have gone.
Yes, well, this is a big issue. I mean, there was a point where if you followed the overall mortality in the country graph, up until about end of March, even early April, there were less people dying this year than had been in an accumulated figure for the last 5 years. So in other words, it was something like, I think, 15,000 less overall deaths in the country. Mm-hmm. And a number of people were jumping up and down saying, oh, well, COVID can't possibly be causing deaths because look, the overall death rate hasn't gone up. Well, I remained rather silent on that issue because I said, well, we may find out something about that. But I now notice in the last 3 weeks there have been 50, I think is it 50 or 60,000 excess deaths over what you'd normally expect at this time of the year.
Yeah.
Now, of course, a number of them are COVID, but a number of them are not, and they're not explained by COVID. And I just was hearing yesterday of a young lad who's just died of cancer, whose chemotherapy's finished when the COVID lockdown started. Oh. I had a patient who had lung cancer who was being treated at Christie, whose treatment and chemotherapy stopped on the lockdown. So people are not even getting this. They're not getting treated for cancer currently. People are definitely not getting treated. They're not having operations that may not be instantaneously life-saving. So, for instance, you've got a heart arrhythmia and you need a pacemaker put in. Well, the likelihood is that you're not going to die, but equally, some of these patients, and if you have implantable defibrillators, people with severe heart failure, their chances of death are very high. An implantable defibrillator can stop that happening. And in a more direct way, yes, there are children who are coming in quite severe ketoacidosis from type 1 diabetes, which is a really severe medical condition because the parents are worried about bringing them into hospital. Yeah. 50% less admissions with chest pain, query heart attacks. What is happening to these people? Well, some of them are probably dying. Yeah. And undoubtedly, some of them are dying. Yeah. And others are not getting correct treatment. And whilst, it's not absolutely perfect, if you have a really severe heart attack and then you get properly treated, you can prevent things like future heart failure, which is a horrible, horrible condition. So the longer term, also there's this immediate increase in deaths from people. I mean, I know in the nursing homes, we had a patient who we battled to get sent in, and they said, well, it sounds like COVID and we're not taking them because there's nothing we can do. And it turned out they had sepsis, and then they died, all right? Because the symptoms are pretty, to the naked eye, to what I can measure, I can't tell you which is which, all right? But I can tell you that they would have been saved if they had gone into hospital. I can tell you that for sure. And the hospitals are very reluctant to bring in people out, especially elderly people with COVID-like symptoms. Well, they may be COVID-like symptoms, and they may have COVID, and it may be right. You maybe can't do anything for them, but how do you know until you do some other tests? So we are definitely. This is not just a zero-sum game where we're saving lives from COVID, and that's all that matters. Another, the economy and God knows what else doesn't matter at all. We are definitely also causing people to die now, right now, every day that would have potentially survived. And we are never going to know what that figure is. We'll never know, because I can't tell you that somebody definitely died of a heart attack who would otherwise have survived. There's no one can tell you that. Yeah. And when you're saying on these figures, well, if we're measuring and saying these people are all dying of COVID, when they're not, we'll also have overestimated the impact of the disease, and instead we did everything right when we didn't. So we're running ourselves into huge, huge problems with understanding what happened that we will never, I think, be able to disentangle. But there is no doubt, that people are suffering, people are dying because of the utter and complete emphasis on COVID. And yet this is something that we're almost it's not being discussed properly. Yeah. Do we know what the hell is happening? Yes, I've worked and I've watched. A&E is like a ghost town at the moment. The hospital wards, and some of them are shut down in ghost towns. These things could have been happening. Beneficial things are not happening to people. On my very, very small area, I've got a problem with my knee at the moment, as I've told you, and it's probably arthritis, and God knows what's going to happen. But my appointment has now been cancelled. So, I'm not going to get seen for probably now a year or something. Okay, I'm not going to die of my sore knee, but that's a downside, and from my point of view, it's a very big downside. But
would you have still gone in to have your consultation or the operation in COVID if it was on if it was offered?
Well, they won't do it. I mean, they're trying to say we've got to keep wards COVID free. I mean, I don't know if I've had COVID. I'm sure I've had COVID. I've been exposed to so much COVID. Yeah. My daughter's working as a junior doctor now. She just qualified, and she's got COVID. She's got no symptoms, except she's lost her sense of smell. I mean, this is another one that drives me mad. Yeah. In fact, our next door neighbor is two doctors, an orthopod and a GP, and they got 5 boys, and 2 of them said they had no sense of smell. They just lost their sense of smell. And yet our experts are just refusing to put this down as a key symptom to say you may have COVID, because it's again, this is like the peacetime generals. Oh, we haven't done enough studies. We haven't got 500,000 people studies. Like, listen, I know it's a symptom of COVID because I've seen about 7 people and spoken to them. It tends to be younger people who've lost their sense of smell, and then in 5 cases they're then found to be COVID positive. So if someone loses this, they've got these down things like it's a high temperature. Well, high temperature doesn't affect about 40%, or cough, that's about another 40%. But always like, and loss of sense of smell, anosmia is the medical term for it, seems to be 70 to 75% positive. So that's a more accurate symptom than anything else we have to say you've probably got COVID. And yet they still refuse to put it onto their list. So if you phone 111 and say, I've lost my sense of smell, they go, well, that's not a symptom of COVID. You go, well, it is a bloody symptom of COVID because it's so unusual to complete. Well, my daughter's come back home because she's done her 8 days of self-isolation, and she, we were eating a meal last night. She can't taste it at all. This is such an unusual symptom in a 24-year-old girl, woman, whatever you're supposed to call people nowadays. That you'd have to say, I've never seen this. I've never heard of this before. Yeah. I've never had anyone come to me at that age and say, I can't smell or taste anything. All right. And we now know that this is the case for an awful lot of people. So the moment someone gets this symptom, she's going, this is COVID until proven otherwise. Yeah. And yet it is not on the list of things. And there was an ENT specialist whinging about this on Doctor's Net, going, why won't they put it on? It's not just me. They will not move at any speed. They're stuck. Like, you read about World War I, don't you, where they were still using, they thought a cavalry charge would clear up the enemy. You're going, yes, in 1804, that was the correct thing to do. But they've got machine guns now, and tanks. Cavalry charges don't work. And yet we're still going for even at the end of the war, they were waiting for the cavalry charge. I mean, we're in this situation where things are changing. You've got to think fast, and they are just we're going to do everything we've always done before. We're going to put people on ventilators. We're going to ignore vitamins. It's gigantically frustrating. Yeah. And you just look at these people and think, if this went on longer, you'd all be swept away because your uselessness and your complete inability to move at any speed that is required would mean that you would eventually just be replaced and said, sorry, you were good in a peacetime, but we're not in peacetime. Go away. We need people who are going to think quicker.
Well, I'm going to be a bit controversial with there, and I agree with everything you've said, but they seem to have been quick at some things. I mean, I've never seen anybody put up like the Nightingale hospitals. I was so proud of the government for doing that, because normally the red tape and the bureaucracy, that would have taken them 20 years normally to do that. But then, on the other side of it, like you say, the inability to say, look, well, vitamins, we know they don't cause any harm. There's some decent evidence, coming out that it works, and look, the Australians haven't got much of it, and they've got, let's go and measure them. Oh, they've got a lot of vitamin D in their system. Oh, look at nearly everybody that's hospitalised. Oh, no vitamin D. I mean, it's like really quick in one way, but an oil tanker in another way. It's just bizarre.
Well, I think I take your point in Nightingale, but that was part of a planned organisational thing that was set into the plans, because they did know something. If this happened, they had that in the background. You don't think they got those hospitals from scratch. This was planned. The army had the stuff. When they brought them in, it was bang, 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 because that's what the army was designed to do in a pandemic. Right. So yeah, okay. But that was part of the pre-existing planning system. Had it been a new thing, it probably would have taken 20 years.
Maybe overpraise them when I shouldn't have done. In fact, somebody just said exactly what you just said there. The government and press have made people so afraid of the flu virus that they are dying at home from heart attacks. The UK death rate jumped up on lockdown. Thank you very much indeed. Gemma says, maybe because Australians have just come out of their summer. Yep, that's what we're saying as well. That's a very good potential. Here's a question, says Keto. How is this any different to any other flu, or isn't it?
Well, it's definitely more deadly, especially for the elderly, than any flu that's been around since, I think, 1967 was the last time we had a really big flu epidemic in the UK. I think 57 was another bad one, and I think it's definitely no worse than 67 or 57 off the top of my head, because I was looking at that recently. It's definitely not as bad as obviously the flu pandemic after the end of the First World War. It's worse than anything in immediate deaths, but of course, everyone talks about this R number, although no one seems to understand what it really means. But anyway, we'll work on the basis that it's more easily spread than the normal flu. So more people are going to get it more quickly. So more people, you're going to have this spike, if you like. The question is the spike, is the area under the spike greater than, say, a normal flu, which kicks around for 4 or 5 months during the winter? A flu in the UK, 35, 40,000. It's difficult to say for sure. The figures are weird, but let's say 35 to 40,000. But we haven't reached that level of death yet from COVID. If it suddenly just disappeared, and if I was going to make one prediction in the world that will come back to haunt me, is I think this disease will suddenly disappear on us, because epidemics, viral epidemics, have a tendency just to go, and then they're gone. And I think this will happen in the Northern Hemisphere. You can hold me to that and tell me I was an idiot in 3 to 4 weeks' time. So if it just goes, then the total number of deaths from COVID, of course we haven't locked down previously, will not be that far away from a normal flu. One of the greatest differences, of course, normal flu kills children in quite high numbers, and COVID doesn't. So there's something weird about it. So it is different. And I think when it came along and no one knew what it was, and it seemed to be wiping people out very quickly, there is obviously, there was something needed to be looked at and done. Whether we've done the right thing or not, I think Sweden's dealt with it much better than we have. But we'll see. I might be proved wrong on that. Other people might be proved wrong. The problem I have is people are looking at Sweden and almost hoping it fails. They're going, more of them will die in the end, and you'll see, kind of thing. Because it's almost like, well, then we'll be proven to be wrong. Well, to an extent, thank goodness we've got a country. Thank goodness we've got a country that we can use as a comparator. It's not perfect, but we can say, what happened there? Did they get 3 times as many deaths as us? Did they get 5 times as many deaths? Did they get half the number of deaths that we got? Because all the different countries are so wildly different in the number of deaths per amounts of population. It's difficult to make absolute certainty. But I mean, Sweden is not an outlier. It's not like, oh my God, 5 times as many people have died. I'd love to see them. I'd love to see them have been shown to have a more appropriate, more effective approach than we had in this country. But I do know that almost everyone I speak to, the medics, they're almost like, well, Sweden, they'll suffer for this, as if they want them to suffer for this. I want them to win, because I think what we've done, it's not just economic. And I did write a thing at the start saying, you have to look at the overall, because economics does not exist in isolation from the rest from health. I looked while this was happening, I was doing a chapter in a new book on heart disease. I was looking at what happened in Russia with the Soviet Union, with the breakup of the Soviet Union, the collapse of their economy and the collapse of their society in many ways. And in Russia, over a 2-year period, there was a 7-year drop in male life expectancy, which makes anything from COVID look like a drop in the ocean. This was 1991 when Russia itself, rather than the Soviet Union, collapsed. I was looking at a graph of death rates from heart disease in Lithuania, which was going like that. And then from 1980, 1989, the heart rate deaths doubled over a 4-year period before dropping down again. And this was entirely due to the economic and social disruption caused by the breakup of the Soviet Union. And then in Russia itself, in 1999, there was an enormous spike in deaths and heart disease rates again. And people say, what happened in 1999? There was a thing called the Ruble Crisis. The Russian economy tanked. It was a gigantic economic depression, followed by a huge rise in deaths. So my concern had been on that. It was, if we shut down the Western economy and more people, the people who are going to suffer are the poorest people, the people in temporary jobs, the people on gig jobs, the people at the lowest level, they're the ones that are going to suffer the most. And if we knacker the world's economy so badly that these people end up with no jobs, this will have a long-term, significant and gigantic impact on mortality and morbidity. We can't suggest this is not the case. It's not just a case of we're saving lives here. It's lives versus lives in the end. And I think it will be more lives in the end if we don't break out of this ridiculous situation.
Yeah.
That's my concern, my real worry.
Let me pick up on that, because I don't know whether I've read it in one of your books or in the many conversations we've had, but you have given me over the last 2 years 6 or 7 examples of social deprivation, big events, migrations, all sorts of things, where a couple of years on from that, or a decade on from that, there was a massive uplift or occurrence of heart disease. And what you're saying is that the danger is, and we know for a fact that stress is one of the biggest causes of heart disease, and therefore if lots of people get out of work, if we have mass unemployment and more poverty, that undoubtedly that releases more cortisol, more stress, and we know that's one of the biggest contributing factors to heart disease. So what you're saying is we've got to find a way to get the economy kicking and rocking quickly, otherwise the death rate as a knock-on effect, a snowball effect, may be as bad as the thing itself.
Oh, maybe many times worse.
Yeah.
One of the interesting countries was Finland, which had the first, after the United States, Finland had the next kind of explosion in the rate of heart disease. And you think, well, Finland's a nice, quiet little country up in the middle of nowhere, and nothing much happens there. But it had the largest forced migrations of peoples in the history of the world, when the Russians decided to kick out about 600,000 people from a region called Karelia into North Karelia in Finland. And the rate of heart disease, and particularly in North Karelia, was gigantic. And I think that it seems quite clear that social upheaval played a major part in deaths following that. And you can see other things. I was just looking at a study from Michael Marmot, who's done a lot of work in the impact of poverty and health and whatever. 2 areas of Glasgow, one called Lenzie, which is posh, awfully nice area, and the other one's called Carlton, which is not so nice. And they're about 4 miles away from each other. And the difference in life expectancy in these 2 areas of Glasgow is 28 years.
Wow.
Which is, just mind-bogglingly huge.
Oh.
And you can see the same effects in America, whereby poor counties can be sitting next to each other across the railway lines, and the life expectancy differences can be 10, 12 years, next door to each other, dependent on the social, what they call social economic scores.
Yeah.
We peril. Of course, people, medics tend to go, it's health, and how can you possibly care about the economy and money at a time like this? Because money and health, whether you like it or not, social deprivation is enormously important for overall health. And if we crush economies around the world, the UK economy may do better than most, but there are other places like India where I just think this is going to really, really wipe out millions of people if we're not careful.
I speak to India daily, because that's where most of my workforce are, and in fact I was on the phone with them at 4 o'clock this morning. And I mean, I respect their Prime Minister massively, Modi, but really bizarre. I mean, just really, really, really bizarre. And they've not had, obviously we've had the furlough scheme in the UK, but very little to zero financial support out there. They've just been told to shut up shop. They are now slowly coming back online, but it could be horrific effects in India. Keisha says, why are none of the 200 plus staff and their families not ill in my local Sainsbury's, and none of my police colleagues or their families are ill? It's a good question.
Yeah, well, I don't think we understand how this disease is really truly spread. So there's a thing called secondary spread, which is the idea with the virus is I give it to Steve gives it to his son gives it to his mother, and it goes through that what we call secondary spread. Well, they've tried to establish what the secondary spread with COVID is, and it seems incredibly low, as in like 10%, but 10% might mean there is no secondary spread, because obviously if 2 people in a household get it, that doesn't mean one gave it to the other, because those 2 people could have got it from another person or another similar situation. It's the same with the flu. The secondary spread, you do get situations where you get a house where one person gets it in the house, no one else gets it. So the question is, how is this spread? And perhaps the spread is not how we think it is. So I think the question is a lot of unanswered questions here about exactly how it's spread. And you're right. I went shopping in Sainsbury's and thinking, you know, if this spreads from person to person when people are closer than 2 meters, there is no way that these staff cannot be getting COVID, because they are getting people realistically closer to them than that 100 times a day.
Yeah.
So why aren't they? Why did bus drivers get it in London though? You know, that was quite a major thing for the transport staff. So there's a lot of very puzzling things. The frustration is the puzzling things are not going to be puzzled over enough. I think people are just going to say same old models, same old ways of thinking. We're not going to have to change our ways of thinking, because it's very interesting with the flu. You'd say, well, Australia gets the flu in their winter, we get the same flu in our winter. It takes 6 months to come over. So what happens if someone flies from Australia during their flu season and then comes to Britain? Surely they should just start the flu epidemic in the UK. Well, they don't. This doesn't happen. And in fact, what they found is that people who've got no symptoms fly over to the UK. There's a little blip of people picking up flu from them, but that doesn't then spread further. So there's more going on than this. It's just like, I give it to you, you give it to them, they give it to them. I'll give it to 2.4 people every time I get it, and that's the R number. This is thinking from kindergarten as far as I'm concerned scientifically. So the answer to that is, I don't think we know the answer to this, but you're quite right. Why are some people getting it and some people aren't? And how is it spread exactly and precisely? And until we can answer these questions, things like lockdown are, you know, why, you know, so we've locked down in the UK, maybe not that effectively. They didn't in Sweden. They've got less deaths than us. All right, they've got less deaths per 100,000 per million. And people say, oh, they're more socially isolated and they're more single patient parent families and blah, blah, blah. But, you know, that does not explain what we're seeing. So
fascinating. It's just fascinating. I mean, I found it fascinating what you said earlier on with the Spanish influenza, that the experimentation they were doing was having people, you know, literally sneezing in each other's faces and they weren't catching it. I mean, it's just, there's so much we don't know, isn't there? So much we don't know. Great question, by the way. Mandy says, hi, great valuable information. Thank you, Mandy. What can I give my fussy eater young children? They are 7, 4 and 5. Oh, Mandy, where do we start? Mandy, have a look at Primal Living on Instagram. We've got loads of food advice. The key thing is whatever you cook for them or make for them, it's got to be flavoursome. It's got to be the sort of flavours they like. Jack, what do we do at home? We do things like we make kale crisps.
We make normal stuff, just with the carbs with cauliflower, rice, cauliflower.
Yeah, my son, I don't know if you can hear Jack in the background there saying we cook what looks like normal stuff, but the rice is actually cauliflower rice. The crisps are actually kale crisps. And don't get me wrong, Mandy, we have off days as well, and occasionally, you know, we don't stick to the rules all the time, but there's lots you can do. Have a look at that Instagram page, I think. Mulder says, Australia, what about the space? Bigger land, they have huge spaces and people are more distant. Not strictly true, Marvellous. I spent a lot of time in Australia, and 99% of the country is just, nobody lives there. So there are more people in cities in Australia than in the UK, believe it or not. So it's not that. I'm with Malcolm that it's probably to do with vitamin D. Well, that's probably part of it. I'm trying to just get so many questions. If you can get them outside around midday, the body can generate over 20,000 of Vit D. Yep, get outside, get outside.
Get outside. Can I say it again?
Yeah, go on. Please do.
Get outside.
Oh, but I might get sunburnt, Dr. Malcolm Kendrick.
Yeah. Well, so you might. Try not to, but you know, I mean, this is this terrible fear again. We've been terrified of going out in the sun and getting malignant melanoma. The evidence again is I'm not enough time to get into that, but just put it this way, that approximately 2,000 people a year die of malignant melanoma in the UK, and the studies from Sweden have showed that women, this is when women with the least sun exposure, right, have a loss of life expectancy that is equivalent to smoking 20 cigarettes a day. So in other words, and a lot of that's due to cardiovascular disease, but quite a lot is due to cancer. So staying out of the sun, you know, the death rate from malignant melanoma as a proportion of deaths is that. The death rate from cardiovascular disease is see that. A reduction in that of that amount, 30-40%, just means that your fears of other things go out the window.
Yeah,
Don't get burned, yes, but it is much more healthy to be out in the sun, getting sun exposure, than to cringe and fearfully from the sun in your house. Yes, don't get burnt, but that's because that's uncomfortable and painful. But I tell you, the two groups in the United Kingdom who suffer the least malignant melanoma rates are farm workers and building workers. These are people who work outside. The evidence that sunshine, natural sunlight rather than sunbeds, increases the risk of malignant melanoma is poor to non-existent, in fact negative. And I'll put that out there, and I know that people will howl with anguish about me making that statement, but I've looked at this. In fact, the British Dermatology Society at one point published a paper saying that there is no evidence that sun exposure increases the risk of malignant melanoma, and that our model is wrong. Now, there is no doubt that you can get other forms of skin cancers, such as basal cell carcinoma, squamous cell carcinoma, rodent ulcers. Pale skinned people in places like Australia get a lot of these. That's not pleasant, but they can be fully excised and removed. Malignant melanomas perhaps can't, but there was a study in the Journal of Epidemiology from the States showing that the people with lower sun exposure in the States were 50% more likely to get aggressive prostate cancer, men, 50% more likely to die from breast cancer, women, 75% less likely to die from colorectal cancer. And these add up to about 100,000 deaths a year. Now, you can say that's observational study, that's fine. But you have to say that anything about malignant melanomas is also observational. The evidence is extremely weak that sun exposure on your skin triggers malignant melanoma. This is, I would debate this with anyone, anywhere, using the evidence. All right, and I think we've been terrified of the sun, which is ridiculous, because it's been up there shining down on us for 4 billion years. And if you believe in evolution, then you must believe that we spend our time outside. Normally, we're designed to do that, and that the idea that this can be harmful to us is just bonkers. So, yes, pale-skinned people in Australia don't go out in the sun for 12 hours a day every day. Pale-skinned people in the Northern Hemisphere, when the sun is shining, get out and get it on your skin. Not all at once in one fast blurt, but as soon as you've got the first bit of tan on and you can just tan gradually, you're fine. And I'll put my neck out on the line, and I will debate that with anybody, because I think we've just got ridiculous. This whole thing's become ridiculous.
And no. This is fascinating. And as a doctor specialises in research around the heart, is it true that sunshine, as well as creating vitamin D, creates nitric oxide, which relaxes the endothelium, so therefore it's going to reduce our likelihood of having a heart attack being out in the sun?
Absolutely. Well, sunshine exposure, you've got nitrates in your skin. The skin triggers that, produces nitric oxide, which lowers your blood pressure more than most blood pressure lowering medications. Reduces the risk of stroke, heart attacks, and everything. It is incredibly good for you. Yes, there's always these caveats. Don't turn yourself into a beetroot by going out for 12 hours in one ridiculous insto burst. Yeah. But get out there and get healthier. And I think it improves your mood. It's good for depression.
I was going to say, does it improve your mood? Because I think it helps produce serotonin, doesn't it? The happiness hormone.
I think that the research into the sunshine, and also, before antibiotics came along, if you wanted to cure things like TB, you put people in the sun with solariums. They understood that sun treatment is fantastically healthy for people. We've lost that. We've seen it as an enemy. The terrible shiny thing is an enemy in the sky. Yeah, it's just bonkers, just utter bonkersness. Yeah,
absolutely great advice. Great advice. Right, I don't know whether you want to answer this one. It's your favourite topic subject. Do statins negatively affect health outcomes if infected with COVID? And in brackets, via reduced cholesterol and potentially reduced ability to fight infection.
Yeah, as you can probably understand, this is something I have looked at. There is a remarkable lack of data on how many patients are on statins when they arrive at hospital. I haven't seen anything. I can't see any evidence on this one way or the other. I mean, my natural inclination would be to say, yeah, of course, they can't be good for you, but I don't know. I mean, there's a study in China showing that once you've got COVID, your cholesterol levels drop considerably whilst you're ill, and then come up again afterwards. And some people have said, oh, well, that just proves. I said, I have no idea what that proves. That proves that when you're very unwell, your cholesterol level drops, and usually cholesterol is being used as a protective substance to protect your body. But that doesn't prove that having a high cholesterol or being on a statin. I can't find any information. That always gives me to worry that the information is not being, people don't want you to know that, because they must be looking at everything when people go in as much as possible. I know that they are. I know in Italy they looked at various medications that people were on, etc., etc. Nothing about statins, the most widely prescribed medication in the history of the world, and yet there is no information to be had. So all I can say is I can't say anything about it because there ain't no data to be seen.
Okay, and so the next one's kind of related to that, and feel free just to say that it puts you in too much of a position to answer it, and in some ways I don't want you to answer it, but I'll put it out there. Would Malcolm recommend to stop taking statins temporarily if infected with COVID, in brackets for 70-year-olds 6 months post-MI on high-dose statins?
Yeah, well, you're right. I never recommend that anyone stop statins. I just say, read the information, find out what you can, make your own mind up. That's how I want people to act in all situations. There's no way I'm going to sit here and say stop your statins.
Yeah, thank you. I thought I'd put it there. Right, our lovely Poppy from work has got a great question, but I've just scrolled. Oh my God, there's hundreds and hundreds of questions. You okay for time, mate?
Yeah, I'll give it another 15 minutes. I'm expecting my bacon sandwich to be ready at 11:30.
Poppy from work says, having been ventilated 4 times myself previously, for non-COVID reasons, of course, could there be any long-term damage from this?
Well, there is long-term damage from ventilation. There's no doubt about that. I don't think anyone disagrees. You know, ventilate last and least and at your peril, because obviously you are subjecting the lungs to something pretty extraordinarily different. You're sticking a tube down, you are pumping air in and oxygen in at high pressure into the lungs, which are a reasonably fragile tissue. Yes, it's not disastrous, but there can be some long-term damage and fibrosis and all sorts of things. So it's not a thing to do lightly to anybody. Absolutely.
Yeah, I know Poppy. She's very conscientious about everything else in her life, so she's definitely doing everything else as well as she can. The government and press fear message is killing people, not the flu. That's an opinion. You're probably right, though. If COVID causes blood clots, can we take turmeric in milk? My mixed race children are 7 and 4, and I'm white, thanks. If COVID causes blood clots, can we take turmeric in milk? I don't have an opinion on that one.
I don't have an opinion either. It does cause blood clots, and in fact, when you go into hospital, you will quite often be put on various anticoagulants if you have COVID. So there are people who say an aspirin is not a bad idea. I don't know if there's any evidence it does any good or not, but we know that aspirin prevents blood clotting following blood vessel damage. So whether you want, I don't know enough about turmeric in that aspect of it to make any sensible suggestion.
Yeah, I mean, the only thing with turmeric, it's when you look at the various scales for its antioxidants, it's right at the very, very top of that scale, but I don't see the two tying there. Andrew says, I applaud you, Dr. Kendrick. Thank you for your work and continued efforts in the face of institutions.
Well, thank you.
And
if I keep being so outspoken, I may not be part of various institutions, really not.
Well, I remember the very, very first time I met you, you'd been taken off Wikipedia that day, you just disappeared. Now a 3-time award-winning author and doctor disappears off Wikipedia. I have no idea, but there you go. People also dying from heart attack.
If I may add to that, somebody sent me a discussion on American news about, not about me, but about that Facebook, if you start writing anything about vitamin C being beneficial in COVID, you will be removed and your comments will be removed from Facebook. There you go.
Well, it happened to me. So I had one post, and within 12 hours, the Advertising Standards Agency said to me, you must take that advert down. And I went, it's not an advert. They went, you must take it down. I went, it's not an advert. They went, you must take it down. So right. I mean, I just put a post up of a picture with me with a face mask on when all the debate was about face masks, and I had some vitamin C, and all I said was, which gives you more protection? I don't even think it was one of my products, but there you go. People are also dying from heart attacks due to stress, anxiety, because their business and livelihoods are ruined. Mortgage, holidays cost them, which government probably won't help them with. Yep, good point. Don't understand that one. Here's an interesting one. Brazil, Ecuador, several other sun-drenched countries have big problems with COVID-19. So don't think it's the warm weather in Australia the reason for low rates. Good point, Jimmy.
I think it's interesting. The Brazil aspect is interesting as to exactly what's going on there. I think that needs to be looked at.
I will say though, Malcolm, in Brazil, certainly in built-up areas, because I was there recently, a couple of years ago, lots of diabetes, lots and lots of obesity. I don't know about blood pressure, but certainly lots of diabetes, and maybe it's a combination of vitamin D and not having an underlying metabolic condition. Where are we? So many questions. Andrew Hunt says the death rate in Russia after the fall is also related to a government reporting during the Soviet era surprised and controlled, but the state. I mean, I don't think we'll know what's happening in Russia because so many smoke. So I mean, it's just going to be so difficult to work out the figures.
Well, you know, I mean, the statistics from different countries are incredibly difficult to work out. But the reason why that you can suggest it's accurate is because at that time there was a system called monitoring trends for cardiovascular outcome run by the World Health Organization, and also had setups in Russia, and they reported exactly the same figures as everywhere else. So I don't believe it's due to government not reporting deaths in Russia. That's a very strange concept to me indeed.
Yeah. Ian says Ed Stoughton interviewing people on R4 Sunday this morning didn't challenge the view that social deprivation is main cause. I would like Malcolm's opinion. Well, I think we've kind of had it.
I think I've told you. Social, as much as anything, it's not total amounts of money, but it is to do with differentials in society. So the greater the differential in income in societies, the greater the effect it has being at the bottom of that heap. So if you look at again at Australia, the probably at the bottom of the heap in Australia would be Australian Aboriginals. And their death rates are just catastrophic, and from cardiovascular disease. Yeah. A young woman in Australia, a young Australian Aboriginal woman, has 1,000 times the risk of dying of heart disease as a surrounding, come from Europe or Asia, Australian. So we were talking extraordinary differences in that population.
Yeah. So it's just as well. Yeah, and some of that has to be us trying to put westernized values and foods onto a population that, because if you go back in time, they had a massive life expectancy, the Aborigines. It's funny. This one you'll like. Keisha, now you're going to love this. This will hopefully keep spurring you on to write even more books and getting your message out. Dr. Kendrick has invisibly helped me enormously. Thank you. 7 months on, from weak on cardiology and off all BP, medication and beta blockers, I've lost 20 kg too.
Well done.
She's thanking you there. Mick says, must be a blue sky, or is there a benefit despite cloud cover? I think there has to be some silver linings coming out. I mean, it is doom and gloom, but there must be some positives to come out the other side. Maybe.
In fact, cloud cover, unless it's like incredibly dense, I think if you get a day with, if I look at it, there's a bit of cloud up there. It's probably around about 80% of the UVB still gets through. So it's it makes not a huge amount of difference if there's cloud cover, and that's incredible, like peeing down with rain and gloomy. So you won't want to be out there anyway. So a bit of cloud cover doesn't make a huge amount of difference.
again, just shows you're on a totally different intellectual level than me, Malcolm, because you got that question and I didn't. I thought he was saying, look, is there any silver lining coming out of COVID? But you're right, that was what he was asking. Just go outside as much as you can. Mr. Silky, a new person asking questions. Prior to 2 very mild heart attacks last year, I didn't take any meds. Post heart attack, the doctor put me on 6 different pills. They were making me so ill, I stopped all of them. Do you think I am mad?
Well, I don't think you're mad. I mean, I think that you know, the cocktail post MI nowadays is around about 6, sometimes even more medications. The difficulty I have is that each one of them, in some very large clinical trial, has shown to have some benefit, not very large. The assumption being that if you add another drug, you get an additive benefit, an additive benefit, additive benefit, additive benefit. The problem with that is no one's ever done that study. No one knows for sure. And when I started doing medicine, they used to say no one should be on more than 5 medications. Nowadays, it's like no one should be on less than 5 medications. But the interactions and problems that can occur from taking 5 or 6 different medications are undoubtedly great. I would look back at that. You mentioned a study of 1 person dying in the last 10 years. And in America, vitamins, well, every year in America, it's been estimated, this is Harvard, this is not me. Every year it is estimated that correctly prescribed medications are responsible for 235,000 deaths per year in America.
Wow.
And that figure is something that just doesn't even seem to get any mention at all. So we are looking at, you know, you have to look at the downsides of these medications. If you're getting horrible adverse effects and your quality of life is absolutely demolished, you maybe wouldn't want to stop them all immediately, but you maybe want to step them down and then just see, perhaps it was only one of them that was causing the problem. Perhaps it's a combination of all of them that's causing the problem. And then you have to make a decision yourself, which I always say to people, what's it worth? Is it worth living an extra 6 months or 3 months or however long this might make you live if your quality of your life is absolutely ridiculously low? You know, only you can make those decisions for yourself. But I would always support people in saying, let's see what happens when we step down. Let's see how you feel. Let's see what we can do. Is there any other way of, say, reducing your blood pressure, like sunshine, whatever? You know, eating different foods and reducing your insulin load and blah, blah, blah. You know, these things can be done. And I would always say to people, it's your life, it's your risk, it's your body. You know, all I can do to you is say, here is the information as well as accurately as I can present it to you on what I think, and then really I can try and help you to make decisions on what you want to do. But in the end, it's your decision, and I'd respect whatever decision that you made, essentially.
I'd like to see GPs understand numbers needed to treat more, because until I got into this space 4 years ago, yeah, I would have thought that whenever a doctor tells me you should take this medication, then I would just take it because it must work 100% of the time. But the reality is no drugs work, well, very few drugs work 100% of the time. In fact, most drugs don't work even half of the time. And therefore, I think more doctors need to be a bit more frank of getting that message across. So it becomes, if you like, an informed decision as opposed to just take this.
Well, I absolutely agree. Although a lot of people don't necessarily want to get involved in that decision making. I'm aware that there are some people who just want to be told what to do. They will take whatever, because that makes them feel secure and safe. Fine, that's a way of approaching life. And if you want to approach life that way, I'm not going to say that's the wrong way to approach life. It's right for you. It's the way you operate. But I think people who have questions, people who have queries, they need to be given the information. And, you know, as you say correctly, you know, with the NNT number needed to treat to have one benefit with something like statins can be in the hundreds. In other words, say, I'm not going to use exact statistics, but say I'm preventing or reducing the risk of dying over the next 5 years, you might need to treat 300 people in order to get one person who gets the benefit. So 299 people will be taking that medication for no benefit. And well, of course, the problem is you don't know which is the 299. You don't know if you will be one that's going to benefit. You know, and these figures are real. These are not. I'm not just making these up. You know, you've looked at them. And so when you're moving to areas like this, you have to say, well, you might think it's worth it. You may believe it's worth it, and that's fine. Then take it. I'm not going to stop you, but I personally wouldn't be taking anything on that basis. It's just a complete waste of time, and especially if it had an adverse effect. It was making me ache and pain in my arms and legs, and I couldn't walk properly. It'd be like in the bin straight away.
Yeah.
So I think we terrify people with the risks, and we overestimate the benefits. And people say, well, if you don't take it, you're going to die. I've heard people say that to me, and I think, you can't say that to someone. That's just such a ridiculous, manipulative, and not correct thing to say to people. But that's what happens.
Yeah. Last two questions, because I know you've got to get off. Last two questions from Steve. What is the actual treatment for someone who is admitted with COVID? Does it depend on the individual doctor, as there seems to be differences in opinion? Just a quick one on that, Malcolm, because I think we've covered that quite a bit.
Well, I think the treatment depends on the symptoms you've got. There is no treatment, or at least no accepted treatment. There's no cure. There's nothing I can give you. There are some people who would, we can talk about vitamins or whatever, but just in general. So until you get very ill and your oxygen levels start to drop into your boots, the treatment is CPAP or ventilation. That's really, to an extent, and obviously fluids if you can't eat and drink. So it's really just support mechanisms for people who are severely ill. That's the treatment, if you like.
Brilliant, thank you very much for that. And final one from Ian. He says, I missed his question earlier on. Sorry about that, Ian. I've just been scrolling up so quickly. You missed my question earlier on. Why is the difference in the BAME community? Is it deprivation, or is it medical stroke, nutritional stroke, genetic? I think you've kind of answered that quite a bit, that it's a mixture of both, is it not?
Well, there's a combination of things. I think there is more social deprivation amongst the BAME community, there's no doubt. There's more front-facing people with the public in BAME jobs. There's definitely, there seems to be more obesity and insulin resistance and diabetes in that population, and there's definitely reduced vitamin D. I think when you take all these things and add them together into the mix, you can start to see why we're seeing some of these differences.
That's a brilliant answer. Thank you very much indeed. Malcolm, thank you, mate. I know your bread butty's calling.
Might be a pancetta butty, actually. I'm getting very posh.
Look, thank you, mate. It's been absolutely fabulous speaking to you. And obviously, we'll keep that dialogue going over the next week. And maybe, although the show finishes tomorrow, it's our last one tomorrow with the Unwins. Maybe we'll do some more podcasts for everybody, because I think it's so refreshing to hear your opinions, because I think you just put it across in a way that us non-medics can understand. And I just always feel with your advice, it really comes from the heart and it's independent. And so thank you very much indeed.
Okay, thank you. You're doing a good job, Steve. Keep it up.
Doing our best. That was the brilliant Dr. Malcolm Kendrick. I hope you enjoyed that. I thought that was fascinating. I've made so many notes, and I'm going to be going back and watching that one again when I get some time, because so many lessons in there about life, I thought. So I've just had the information from Jack that today's food fact, the sardines, was the last food fact. So what happens now? Do people email us, Jack?
Yeah, there is an email, questions at the food bank show. Apparently it's not working, but we will get it working.
Right.
Send them in, and then tomorrow we will announce the winner.
So we're going to put are we going to put on this video today then the email address, or do you know what it is?
The email address is on. We will make sure it's working, but we've put it up.
Where is it? I can't see it.
It's on the chat.
Oh, is it on the chat?
Yeah.
So right. So my understanding is you email us to the email that's on the chat, the list of all the different foods, and then if lots of people get the same answer, maybe like 20, 30 people get it right, then I'll tell you what we'll do. We'll then rip them up and put them in a hat tomorrow, old-fashioned way, Jack, yeah?
Sure.
And get one of my kids to come down.
We'll find a way to do it.
Yeah, okay. So today, email the address that's coming up in the chat. If for some reason that doesn't arrive, email steve@primalliving.com or the email on the chat with the number. Just list as many food facts as you can, and then if we get a tie, a joint heat, then tomorrow we'll pull them out of a hat. Tomorrow is the last show. Honestly, I've loved it. Jack's loved it. We could go on and on and on and keep these going, but Jack's got to, he left university the other week thinking, I can have a lie-in now, and he's been getting up at silly o'clock every morning, so he needs a bit of a break because he's got his first work placement coming up in June. I've got to go back to work on Tuesday. I've been going to work every day anyway, but like proper, like early doors. So thank you to everybody. Massive thank you to all your questions today. Thank you for everything that's helped us with Just Giving. If you can make a final donation today or tomorrow, that would be fantastic to help put food on the table of people most in need in the UK. Massive thank you to Malcolm. Massive thank you to Jack, and to you at home. Stay safe on this lovely Sunday afternoon, and we'll see you here again tomorrow for our final show at 10 a.m.
Last year, food banks in the Trussell Trust's network distributed almost 1.6 million three-day emergency food supplies to people in crisis. That's a 19% increase from the previous year and 73% more than what was distributed 5 years ago. The main reasons for people needing emergency food are benefits not covering the cost of living, or delays, or changes to benefits being paid. People are being pushed into poverty because there isn't enough money coming in to cover the costs of essentials. It's not right that anyone is forced to turn to a food bank as a result. We all have a responsibility to play a part in ending hunger and poverty in the UK. Together, we can make it happen. This can change.